India is called the diabetic capital of the world. Tell me, Rajiv, is it merely because we have so many people become the capital of almost any medical condition?
The numbers tell us that we are the second largest people with diabetes. But apart from that, the prevalence tells us that it's very prevalent in our population. Earlier, we used to define obesity with probably a BMI or height-weight ratio or probably a waist circumference or stuff like that. But today, at any age group, Indian has more body fat as compared to a age-matched Caucasian. Jaggery has got some multi-minerals. That's why people think it's to be healthy, but that's not the case.
It's not the case.
India is unique because obviously we are the second largest population with diabetes, but we are the largest population with pre-diabetes.
Really?
Yeah.
I didn't know that. So while Jaggery, of course, is a eye-opener for me because I thought having a mithai with good is good enough, but obviously not. Can I use honey as an alternative?
I think honey is the grandmama's recipe for everything, but is the caloric content is very similar to sugar.
Okay.
So excess of honey or even using it as a natural ingredient is going to increase your insulin resistance as such. So honey as a therapy or honey as a sweetening agent doesn't change the caloric value of it.
Okay. So whether it's sugar, whether it is Jaggery, or whether it's honey, eventually means the same thing.
Absolutely.
Okay, interesting. Now we know that oral treatment in diabetes has evolved significantly over the last 3-4 decades. What's been your experience? Could you just take us through how that has truly changed the management of diabetes?
Fantastic question again. So till 2.5 decades back, we only knew that there is insulin resistance and your pancreas doesn't make insulin and it's all about the pancreas.
Right.
Today we know that there are 8 other defects in other organs which contributes to diabetes.
Okay.
So it's not just your pancreas. So your liver is also equally involved, your brain is also equally involved,
Right.
your gut is involved, your muscle is involved, your fat is involved. So there's a lot of other organs contributing. So it is like multiple organs are talking to each other and formulating a plan before you become a diabetic. So a lot of patients think that I just went out for a vacation and I got sugar. But this plan is on for last 5 to 7 years. So in that respect, the drugs have evolved that way.
Okay.
So drugs have actually understood the disorder better. And now we are able to treat the pathophysiology of the drug, of the defect.
So the root cause.
The root cause.
Not just the symptoms.
Absolutely. And what has evolved is that today we are treating the blood sugar based on the complication that the patient has. So suppose the patient has heart failure, then the drug is different. If the patient has multiple risk factors for heart disease, it's different. If the patient has an established heart disease, it's different. If the patient wants to lose weight, it's different. If the patient has a lot of insulin resistance, it's different. So the drugs are chosen also based on complications which the patient has, rather than just the blood sugar.
Blood sugar itself. But are you able to identify the pathophysiology? I mean, is there a diagnostic way to do that? And is it a clinical way or is it history or is there some way to know?
We have not yet reached that level where we could say that 30% of your diabetes is from the liver and 40% is from the pancreas.
Okay.
And we have still not been able to. But I'm sure over a period, you will have that thing coming in because you have certain therapies which will be directed towards the liver and help in liver not producing enough sugar. So you will have those kind of evolution coming.
More targeted therapy.
Absolutely.
But today, I mean, if you were to look at your first line, second line, third line, what would those common, drugs be, or what category of drugs would you use as your first line?
So today, the drugs that we use are mainly to prolong the life and improve quality of life.
Okay.
So it's not about blood sugar control. You can control sugars very easily.
Right.
So the newer class of drugs, which comes like the SGLT2 inhibitors and the GLP-1s, come much higher.
Okay.
Much higher than many other drugs.
Okay.
And metformin also comes in. So these drugs prevent death, prolong life, and there are a lot of hard evidences on it. So we can't ignore them as such.
Okay.
If the patient cannot use them, then there are a lot of other groups of drugs. There are older groups of drugs also.
Okay.
But we have evolved from being just centered around controlling blood glucose to multiple other defects which a patient has.
I think this is a great takeaway that the pharmacotherapy, how it has evolved from merely targeting blood sugar, but one is looking at pathophysiology and second is looking at the quality of life, longevity, complications, side effects of diabetes, and managing those, while blood sugar, you're saying, is still easily manageable.
Absolutely.
Very interesting. Excellent. And when do you consider insulin? I mean, I know in type 1 diabetes, you have to consider insulin right up front. But since majority of the patients are type 2, when do you decide that, okay, now it's time to bring in insulin? And I know insulin also has evolved significantly like oral drugs have. So this whole area around insulin, because people are very fearful who have to take a shot every day.
So I think there's a lot of priming and sensitization to insulin which needs to be done early.
Right.
A lot of people believe that insulin is given as a punishment to me because I didn't follow guidelines or guidance. And that's need to be taken out. So insulin can be given at diagnosis also. If the blood sugar is very high, patient has lost a lot of weight, or there are a lot of symptoms of high sugar. Obviously in type 1 and gestational diabetes, insulin comes very fast. But if you have a complication related to pure blood sugar control,
Right.
Which could be a bad neuropathy or a retinal problem, then insulin comes in early.
Okay.
But majority of usage in insulin today is still when the oral drugs fail in people with type 2 diabetes.
Right.
And insulin has evolved. The biggest hurdle to insulin has been low sugars and
Right.
the absorbability of insulin. So that has evolved. Now you are getting better designer insulins with low chances of hypoglycemia. Next year we'll have a once a week insulin also coming into
Once a
India.
week?
Once a week insulin.
But given exactly the same way as regular insulin?
Absolutely, given exactly the same way. It's once a week basal insulin coming in.
Okay.
So if you are only on basal insulin, so from 365 pricks, you're going to come down to 52 pricks.
So what dad takes, Rhizodec is what you're saying is
Yes.
once a day.
Once a day will become once a week.
Once a week. And will have good control over that week.
Absolutely. So that's what I'm saying, that not only in sugar control, there is evolution in improving the quality of life of patients also.
Sure. But short-acting insulin still has its role.
Short-acting insulins also are becoming very defined because they are getting shorter and shorter and well-defined. You are also going to get a lot of patch pumps coming in, which you can just use and throw.
Okay.
You will see the inhaled insulin coming in the next 1.5 to 2 years, which is going to be a replacement to the shorter-acting insulins.
So let's see. So you're saying that insulin will now not only come in the injectable format, it will come in the inhaled format. It will not come in a daily dose. You can even give it as a weekly dose. Is there any chance of it becoming an oral form?
No, oral insulin is still very far away from reality.
Okay.
And the beauty of insulin today is that you are able to initiate and titrate very finely.
Okay.
Now that is where the challenge lies with this once a week or inhaled insulin, that fine titration is not occurring.
Sure.
So it doesn't mean that every person who's on injectable will go on to this therapy.
Sure.
But probably a large majority will go on to this therapy where the fine titration is not required. And you just have to supplement insulin, and there are other drugs also to take care of it.
So if there was one patient who was diabetic or who is diabetic and who was okay to be given any kind of treatment, would you prefer insulin over oral treatment in any patient that, say, since he or she is not averse to injectables, let me only give this person insulin because I know the control will be better?
So if you had asked me this question 15 years back,
Yes.
my answer would be yes, it would be insulin, because a person is a diabetic in whichever way, whatever form of diabetes, his insulin is not working. But with the robustness of evidence that we have seen with multiple other drugs, where I said that you can prolong life, you can
Right.
prevent heart failure, you can prevent kidney disease, I think insulin comes lower on my list now.
Okay. Which is very reassuring for patients that, diabetes is not the problem that everybody thinks it is.
Absolutely.
I mean, it is there, but it can be better managed than ever before.
Absolutely.
Excellent.
Absolutely.
We had touched upon this earlier, but maybe a little bit more about this whole concept around insulin resistance and insulin sensitivity. I think people get confused first, what is insulin resistance, and then insulin sensitivity or responding to insulin. Sometimes people even taking insulin don't respond to it well. So maybe if you could demystify this simply, What is
So
insulin resistance?
I think it's kind of blown out of proportion, because it's like, why are Indians dark? We have excess melanin, that's why we are dark.
Okay.
So we are all insulin resistant. Insulin resistance means that your insulin is like the vehicle which takes your glucose into tissues and
Right.
then makes them spend energy.
Right.
Now, when this does not occur properly and your glucose is stored in a wrong place, is insulin resistant. So
Right.
we all are insulin resistant. Whether out of insulin resistance you get obesity, or you get high cholesterol, or you get blood pressure, or a lady gets PCOS, or you get an NAFLD, is different.
Okay.
So
And when you say we all, meaning we Indians?
all Indians.
All Indians.
All Indians, majority are insulin resistant.
And it's again a genetic cause?
It's a genetic cause. You're making more insulin to take care of, and it's purely because your carb intake has been higher,
Right.
and you're producing more insulin. And finally, you have had more poor quality insulin taking care of the same blood glucose.
So basically, to explain to people that our basal level of insulin is much higher than, say, a non-Indian would have.
Absolutely.
We need more insulin in our
Absolutely.
bloodstream to
Absolutely.
do the same effect as compared to somebody else who will need a slightly lower amount of
Absolutely.
insulin.
In very simple language, that's right.
And because you have higher level of insulin, it can lead to certain other conditions.
Absolutely. You have excess insulin would lead to probably a menstrual irregularity in a teenager,
Right.
leading to PCOS, or maybe some features of insulin resistance like darkening of skin may come in, especially nape of the neck.
Okay.
You may develop atherogenic cholesterol problems.
Right.
So in what way that excess insulin resistance manifests can be different in different people.
But can we say insulin resistance as a precursor to diabetes? Is that almost certain?
Yes, insulin resistance is the metabolic environment inside.
Right.
A lot of people want to define it outside.
Okay.
There are specific modeling to define it.
Right.
Just by doing your insulin levels, you can't call somebody as insulin resistant, which is what many people do.
Correct.
Do an
Fasting
insulin,
and-
fasting PP insulin and call you. No, there are specific modeling to call it insulin resistant.
Understood.
So it is the environment inside the body which is insulin resistant.
Right. And talking about environment, I've seen recent usage of, CGM or continuous glucose monitoring. It's sort of, what's been your experience? And, I've seen articles which talk for it, which talk against it. The whole fad in the fitness industry of putting a CGM patch. What's been your experience?
So again, whenever we talk about technology, obviously there are going to be two parts to it. But here, what we are talking about is something where you are able to offer a complete difference to the patient. Like when we do a finger prick,
Right.
we are looking at one snapshot reading. When we do an HbA1c, we are looking at something which is a long term.
Right.
A CGM is more like a movie we are seeing ups and downs.
Right.
But one needs to understand that when we're using a continuous glucose monitoring, we are using the interstitial fluid glucose compartment. When we are doing this finger prick, we are using the blood glucose
So
compartment.
CGM is not blood.
Is not blood.
Right.
And all our complications, all our data, everything is on blood glucose and HbA1c. So we are trying to correlate that to interstitial fluid glucose.
Okay.
Interstitial fluid glucose is not for people without diabetes. The fad that let me put one CGM and let me see which food stuff makes my sugar go up is absolute rubbish.
Okay.
So it is only for people with diabetes, and it's only for finding out your patterns. And nothing is there in the world today which can give you patterns, and patterns are very important to find.
Sure, absolutely.
So once you know the pattern of an
patterns, you
individual,
mean trends.
trends.
When do I tend to have high sugar? When do I tend to go into hypoglycemia?
Absolutely.
Based on which you can calibrate and titrate the treatment.
Yes, exactly.
So it's meant for that.
It's meant for that.
It's not meant for the fitness industry the way
It's not meant for the fitness, and is also not meant for the absolute level of sugar.
Right, okay. So what percentage, if your 100 patients, how many of them would you give CGM to use?
5% because of the cost. It's an out-of-pocket expenditure.
Okay, but if cost was not a barrier, would you?
Everyone.
Oh, really?
I could find out a lot more about the patient, because the patient will never come up with these details.
Correct.
You could find out a lot more of his.
So affordability would allow you to control and manage sugar much better with the patterns or the trends that you would get from this. So,
Absolutely.
So it is a boon.
It's a boon.
It's not that I have seen when dad had put it, he would put a patch, and every time he would check it and suddenly sugar would go up and he would panic. Oh, maine ye kha liya and this happened,
But this is what is naturally occurring in him even a decade back, but he was not monitoring, so he didn't know.
Yeah, I mean, he would eat dessert and he would not check it.
He would
Now
not
he's
check
checking it.
Now he's checking it, and it's easier to check you. There's no pain involved.
pain, yeah.
And at the end, when you get an HbA1c of suppose 8.5, then you say, "Oh, last 2 months I've done this wrong," But there's no way to correlate. So CGM helps you identify a lot of hidden lifestyle and hidden movements which normally patients don't.
But this is a great takeaway that if affordability was not an issue, you would give it to everyone.
Patient. Yes, absolutely.
Amazing. Okay, great. One of the things that people don't pay attention to, and I think like pre-diabetes I spoke about, the other thing that is I'm passionate about is letting people know why is it important to keep your blood sugar under check. It is because high blood sugar will lead to complications. So what keeps you worried when you see a patient of diabetes? In your 100 patients, you must have seen so many complications, and I know diabetic foot is a passion subject for you. But if you were to educate the audience that what keeps Dr. Rajiv Kovil awake when it comes to complications?
I think the poor awareness of complication is what I get little perturbed and disturbed by. And that is what is missing, because a lot of patients believe that if your sugar is well controlled, you're not going to get a complication.
Okay.
So our complications have also changed in the last 2 decades. So earlier we were classifying as micro and macro. So
Correct.
You had kidney, retina, nerve, and you had heart disease and foot and things. But it has undergone a tremendous change. Though a newer classification has not yet come in, but the new classification are going to be infections, very, very common.
Okay.
You have cancers, very common.
Okay.
Arrhythmic deaths, very common. Heart failure, very common. Affective disorders, very common. Degenerative disorders like dementia, very common. Mental health disease, very common. So our complications in diabetes in 2024 is different from the complication in 2000. Though we do not have a classification, the complications we see is very much different. So we are seeing more heart failures, we are seeing more infections as compared to 20 years back. We are seeing more NAFLD, for example, as compared to many, and people progressing from NAFLD.
This is a great opportunity. Maybe if you could, spend 2-3 minutes on just educating the audience simply. How should they look at complications? One is, it's not only about the level of the blood glucose, but it's also the duration.
Absolutely.
So both contribute.
Absolutely.
And what should, how can we create more awareness with the audience?
I think the awareness comes when a person decides that investment of one's health is important. Today, if suppose somebody spends some money on blood tests and nothing comes out, he feels that
it's a waste.
It's a waste. So when you change that mindset to investment rather than expenditure, then is when you try to do many, many things and do that. And why we need to do that? Because a lot of complications are there which can be prevented if you catch them early. So right from heart failure to infections to NAFLD, if you don't screen these people...
NAFLD, you mean fatty
non-alcohol, more than 5% deposit of fat in the liver is called non-alcoholic fatty liver disease.
Right.
Today it's called as MASLD, which is metabolic dysfunction associated steatotic liver disease. So there's a nomenclature change in that. Right. But it remains the same. The underlying problem remains the same. But we need to screen more because we are seeing more of this. We are seeing more liver problems today as compared to 2 decades back.
Right.
Foot problems have gone down over a period of time.
Okay.
Probably people are taking better care of their foot. We are seeing more retinal problems as compared to 2 decades back.
Okay.
We are seeing more macular edema. Probably we have better diagnostic tools today.
Sure.
Or better treatment today. But we are seeing more Alzheimer's and more dementia in people with diabetes than earlier.
Right.
The cancer rates are 20% to 25% and certain specific cancer up to 30% higher in people with diabetes as compared to people without diabetes.
Okay.
So there is a need for screening, and problem is that you can't screen for all this in all the patients.
And kidney, is that still...
It's increasing. Almost 30 to 35% of people with diabetes end up with kidney disease. It's increasing year after year.
So if we were to sort of just put a top-down complication risk, number 1 would be kidney still?
Kidney remains number 1. Heart failure is higher than heart attack, which we call as myocardial infarction. Higher heart failure is very, very much there. Retinal problems are on the increase. So are many infections. Lung infections are becoming very common. Soft tissue infections are getting very common. Abscesses are becoming very common. Cancer.
And like you said, Alzheimer's, which is now also called type 3 diabetes.
Type 3 diabetes, because the defect is insulin resistance there also.
Right.
And some of our treatment of type 2 diabetes, like the GLP ones, have been tried there, and in future you may get a labeled indication for use in Alzheimer's.
Right. Interesting. I mean, this is completely different than what, I might have thought that, as you said, the microvascular and the macrovascular completely changed. I was reading somewhere recently that this whole, craze about semaglutide, Ozempic, it's touted to be $100 billion market. Would you like to throw some light on how semaglutide has totally sort of cornered everybody's attention globally, and why is it still not available in India?
We have 100 million people with diabetes, but we have 350 million people with obesity.
Right.
And obesity is growing faster than diabetes. And there's no treatment for obesity. We have not recognized obesity as a disease or disorder. So there's no ICD, so-called classification of obesity.
Right.
Obese man is considered prosperous. A man who loses weight is considered as having a problem. So there is a cultural problem, and obesity is driving problem. Having said that, this therapy, GLP-1s and where semaglutide comes in, they have not only shown to reduce weight. So there are a lot of treatments earlier also, but nothing to this extent of losing 15% weight.
Right.
But apart from losing 15% weight, what have they shown is that there is your resolution of your liver fat, resolution of your blood pressure, there's resolution of lipids, your blood glucose medicines can go down and may stop. And lastly, also you have cardiovascular studies which says that apart from losing weight, you are able to prolong survival and prevent cardiovascular events. So that makes it important.
Wow.
Anything which can reduce death in a person,
right,
is a superior product. So
correct,
the cost comes later on. A lot of people across the globe use
semaglutide is almost like God then.
Absolutely, but a lot of people use it for the cosmetic results they get.
So semaglutide, same thing as Wegovy, same thing as Mounjaro. And when will it come to India? I mean, you think there's a big market for that in India also?
So semaglutide is in two formulations. One is an oral one, which is already in India for the last 2.5 years. It's called Rybelsus.
Okay.
The injectable one, which is approved for diabetes, goes by the brand name of Ozempic.
Okay.
The same product, when it is used for obesity at a higher dose, it goes by the brand name of Wegovy.
Okay.
Mounjaro is the commercial name for a product called tirzepatide. Semaglutide is a single GLP-1.
Right.
While Mounjaro is what we call as a twin creatine. So there are two hormones in that.
Okay.
And that in studies have shown better weight loss and better other parameters as compared to semaglutide.
Okay.
Both have got an approval in India, but the demand across the globe is higher. And that's why, and the capacity has not scaled to a level where they can supply every part of the globe. So in spite of an approval, but we are expecting it next year.
And you see a big market for that in India?
I see a huge market for that in India, purely because now we are treating the variables that we are treating, the HbA1c and lipids and so. So we are not treating obesity. We need to treat obesity.
So you're saying the market for obesity is bigger than the market for diabetes?
The market for obesity is 3 to 4 times bigger than diabetes.
And that's where the target would be. Amazing. You had briefly spoken about a disposable pump. Maybe you could just talk a little bit more about that, and is there any future like, pancreatic transplants or artificial pancreas or pancreatic pumps? Is there something like that that's on the anvil? So the present group of pump which we have is almost an automated device. It's connected to a continuous monitoring system, and which is called as a sensor augmented pump, and it's able to deliver dosages based on the blood sugar value. So it comes very close to what we call as an artificial pancreas. The patch pump what I spoke to you about is not for a type 1 diabetics. Patch pumps are mainly for people with type 2 diabetes, and they are for our regular insulin or a short acting insulin during the day. So instead of injecting during the day, you have a small patch pump where you inject
as per your requirements during the day, and that patch pump remains for 3 to 4 days.
Okay.
So that's a patch pump. While pancreatic transplant is happening in our country, a simultaneous pancreatic and kidney transplant is happening in our country, mainly for people with diabetes and coexisting kidney failure. That's where the indication is higher.
Okay.
Pure pancreatic transplant does occur, but not so common. But the future is there's going to be a lot more than just pancreatic transplant. You're going to have islet cells, you're going to have cells which will go to the liver and then work like the insulin. The
And
insulin
these
producing
transplants
cells.
are again only for managing diabetes.
Absolutely. Also kidney failure. So simultaneous
Right, of
pancreatic
course,
kidney
yeah.
transplant is
Right.
where the indication is higher.
Sure, sure. And these pumps, I mean, do you give it to patients
Yes.
in India?
Yeah. They've been there for the last decade or so.
Okay.
But the main indication is people with type 1 diabetes.
Okay.
Some type 2s still buy it, but who are really have a lot of variation in their blood glucose,
Okay.
they will also benefit. But indication is type 1 diabetes, especially a type 1 diabetes who's undergoing pregnancy.
What do you do with patients who don't respond to insulin at all?
You have a lot of drugs today. That's why I said there's a revolution in the drug. And if you're talking about type 1, where the patients don't respond to insulin, that's not going to happen because a type 1 is not a pediatric type 2.
Okay.
The insulin resistance is very low.
Okay.
The insulin deficiency is higher.
Okay. Okay.
So,
right.
but still today, we have that mix where you have a type 1 who's become obese. So,
Right.
he's also insulin resistant.
Okay.
So, you require higher dosages of insulin, but we don't have any therapy which, as oral drugs, which you can add on to them.
Okay. But don't have too many patients like that.
Off late, yes. Off late, yes.
Okay.
Because the younger generation is growing fatter.
Right. Right. I wanted you to just quickly talk about your project, which is the Project Blue Dot. Maybe you can just explain what is that and how is that making a difference to people?
So multiple projects, Sanjay. That Blue Dot was where I realized that we advocate patients to eat healthy, and we are not changing the environment at all.
Right.
We wanted to make an environment where a person with diabetes could identify a healthy food for him.
Right.
And we want to define that healthy food. So we have
Sure.
defined that healthy food. But it has not been a success because we didn't end up doing a large study on it or spoken to authorities where they could standardize what a diabetic friendly food is. We're not even saying that it is a diabetes food. Diabetic friendly food.
So
So
it's like saying you put a red dot for non-veg and green dot for veg.
So if
You put a blue dot for diabetic friendly
so
food.
whether it's in a supermarket, a person with diabetes picks up the blue dot.
Right.
When he goes to a restaurant, like
Orders.
yes, he orders the blue dot. He has a choice, but he will, if he wants, he can order. So
Right.
it's not that a person will come back and say, "Doctor, what do I get? How do I choose?"
Correct.
So it's easier for a person to choose because food labeling is not easy. And reading food labels is not our cup of tea.
Sure.
Our people with patients are not able to do that.
Right.
So that's the problem. The other project that we are really working on now is called Rang De Neela,
Right.
where we are trying to get patient journeys on a canvas, and we are trying to inspire people living with all chronic conditions, not like diabetes. It could be cancer, it could be heart disease, it could be liver disease, liver transplant, kidney transplant, and we're giving them hope that there is a lot more you can fight, and we are showing them struggles of patients where they've become victorious.
Sure.
So that's an inspiration for a lot of people who see that if I get a problem, then that's the end of the story.
So patient success stories. To
Patient
motivate
success
others.
stories coming on a canvas.
Wonderful, wonderful. And let's end by the story that's closest to you. I know that your mother is a diabetic, and she's been somebody that you have sort of managed in a very special way, I guess. So that story is probably the closest to you from a doctor-patient relationship.
Oh yes, that's the closest to me. And so whatever I believe for patients or for my family, I believe for everyone.
Right.
So when my mom had diabetes 25 years back, and that time I considered that insulin is the right therapy for her because at that time insulin was. So she has been on insulin from day one.
Right.
And we've had and her sugars have been quite brittle over a period of time, and then we put her onto this monitoring device, which is our continuous glucose monitoring system. So for the last almost 3.5 to 4 years, she's constantly on the CGM device.
Right.
And that has helped her, that has helped me manage it remotely also, and helped her in changing a lot of her patterns. So I think accepting technological advances, if we can help the patient not only in his sugar control, but importantly in my mother's case, the quality of life.
Right.
You know, and it has shown a drastic improvement. So I think the closest story to me is that she's had a lot of medical issues. She still has a lot of medical issues, but we've been able to tide over it with the advancement. So now she's also on advanced insulin, advanced CGM device. Thankfully, thanks to God that we've been able to tide over all of them as such.
Wonderful, wonderful. Rajiv, thank you so much. I know there's so much more that we can talk, but we'll continue part 2 when we'll talk about obesity.
Surely, Sanjay.
So thank you for joining us today. This is my channel, Unburden Your Health, where we help bring you insights from experts like Dr. Kovil, who help you manage lifestyle and your health better. So until next time, take care, stay informed, and stay healthy.